Hello. I'd like to talk today about the three models of heart failure. This is sort of how our understanding of heart failure has changed over the last, say, half century or so. So we have the cardiorenal model, which was what we understood in the 1960s. We'll go through this first. I guess the best way to describe pictorially is basically you have the heart and you have your kidneys here. And what does the heart do, right? The heart's a pump, and it pumps blood to the kidneys as well as the rest of your body. And the kidneys, in some way, that's how you make urine and get rid of fluid from the body. But your kidneys also have the ability to retain fluid as well as salt. And that has a bit of an impact on blood volume. So the kind of idea is in heart failure, your heart is not as efficient as it used to be. Say it doesn't pump blood as well as it used to. The kidneys can sense that. They realize that I'm not getting as much blood flow as I'm used to. So what the kidneys will do in response is that they will hold on to salt and water. So we'll say H2O and NaCl. And by doing so, you bolster blood volume, and by bolstering circulating blood volume, you fill the heart better. So maybe the heart is pumping at 30% efficiency. Well, if you fill it better, then with each squeeze, you'll still be able to pump more blood, and the kidneys love that. And initially that helps, and we call that a compensatory mechanism. But over time, if you hold on to lots and lots of water, your blood vessels can only hold so much fluid, and you end up increasing pressures within the veins. So for example, if it's left heart filling pressures rising, well, that kind of backlogs pressure into the pulmonary veins, which then backlogs into sort of the capillary bed, and you end up having really shifts of fluid into the interstitium, and that's what can cause pulmonary edema. Now, say if you had right heart failure, then you have systemic congestion, so you can congest the liver, congest your legs, so you get peripheral edema. So that was sort of our understanding of heart failure in the 1960s, and the way you sort of treated it was with furosemide or other diuretics. And the whole idea here is, well, if your kidneys are holding on to fluid, well, we'll tell the kidneys to get rid of more fluid, and you sort of treat the heart failure symptomatically. People feel better if you, in this situation, if you give furosemide, they'll wee out all that extra salt and water, and that will clear the pulmonary edema. It will also clear the peripheral edema. The thing, though, is that the furosemide didn't make a difference to people surviving heart failure. It didn't stop the heart failure from progressing and worsening over time. So that was our understanding way back when. Then we move on to sort of the hemodynamic model, and this is sort of the 1980s. And this is where I sort of need to talk about echocardiography. This echocardiography is where you have an ultrasound that allows you to look at the heart and allows you to measure how well the heart is pumping. So let's just take the left ventricle. And let's say in diastole, which is the period of time where the left ventricle is filling, you say you fill 100 mils. And your heart's not a perfect pump. If it was a perfect pump, you'd fill 100 mils and you'd pump 100 mils out. And that's not the case. Actually, a normal heart, you might pump out 60 mils. So 60%. And this is where we kind of talk about the left ventricular ejection fraction, LVEF. 60% is normal. And let's say if someone had half of that, 30%, well, then that's heart failure with reduced ejection fraction by half. So in this particular patient, if they had an LVEF of 30%, then they're only pumping out 30 mils with each stroke of the pump. So echocardiography was sort of, I guess, invented in 1950s, but the sort of developments of it occurred over the next few years. In the 1980s, you could actually measure all of these things. And now, so this is kind of where it gets a little bit interesting. So in heart failure with reduced ejection fraction, well, how do you treat heart failure, well, you can try and get the heart to squeeze a bit more. So from 30, how we bolster that 30% closer to 60? Or you could give inotropes. An example would be dobutamine. This is a medication. It's given as an infusion. It's a beta-1 agonist. So it's kind of is similar to adrenaline. This particular medication will go to the heart and it will bind to the beta-1 receptors in the heart muscle and then make the heart squeeze a bit harder. And if it squeezes a bit harder, then well, that 30% your stroke volume will go up. So important equation here is, if I sort of remember correctly, cardiac output equals heart rate times stroke volume. These are sort of key things here. So if you want to improve your cardiac output, you can either increase your heart rate, pump more often, or you can try and increase that stroke volume, which is the key problem here. The hemodynamic model also talks a bit about vasoconstriction. So basically in heart failure, this is a state where the blood vessels in the peripheries are quite constricted. And what that ends up doing is that increases afterload. So the kind of, should we say, the load at which the left ventricle is pumping against. So basically your afterload is increased by vasoconstriction, so you could try and give medications that vasodilate. And by doing so, the heart, this here, the left ventricle, if you vasodilate, it's not pumping against as much resistance, making it easier to deliver, say, more stroke volume, more cardiac output. So we ended up, giving things like, I guess, GTN or nitroprusside examples of vasodilators. And again, so, you give inotropes and that seems to help improve cardiac output, and you give vasodilators and that seems to reduce afterload, which also seems to help. But these medicines also didn't prove to reduce progression or reduce mortality in heart failure. So there needs to be, there's more to it than just that. Then you kind of go to this neurohormonal model, which is sort of the 1990s, early 2000s. This is where things get quite, I guess, interesting. So where does heart failure come from? So our understanding is the heart's all fine and dandy, it's normal, and then some kind of injury or insult happens to it. Let's just say, heart attack, a myocardial infarction, or maybe arrhythmia. There you go. So there's an injury to the heart, and the heart doesn't like that, and the heart tries to recover over time, and in its sort of recovery, it activates a bunch of neurohormonal systems, and there's this sympathetic nervous system. It's activated, and the renin, angiotensin, aldosterone system is also activated, and they kind of all act to initially help, so compensate, but actually over time, the action of this actually produces direct cardiac damage and causes remodeling of the heart in such a way that doesn't help it over time. And in fact, that's how the heart failure progresses over time. The heart maybe it becomes a bit thicker, hypertrophied, but then it becomes dilated. So if you were to try and prevent these mechanisms from over time changing the shape of the heart and progression of heart failure, we can try and block these systems. So how to block the sympathetic nervous system? We use beta blockers. And for RAS, that's your ACE inhibitors and ARBs, which sort of block along the angiotensin side of things. And then the aldosterone side of things, you've got your mineralocorticoid receptor antagonists like spironolactone. In more recent times, we now have RNEs, so sort of a combination of angiotensin receptor blockers as well as neprilysin inhibitors. So an example is Entresto. And then there are other drugs that seem to be helpful in one big class of them is the SGLT2 inhibitors in patients who are diabetics and also have heart failure. But that's a whole different talk for another day. And the kind of ins and outs here is that by blocking the actual neurohormonal mechanisms that cause heart failure to progress over time, well, then you'll reduce progression, you'll improve mortality, and also improve quality of life. So this is the sort of, I guess, our understanding of heart failure, or my understanding of heart failure at a reasonable sort of summary level, at a basic level, and I hope this was helpful. The pen today is a Muji fountain pen. I quite like this one. Let's just show. It's quite a nice nib. It's very smooth nib. Steel, 25 New Zealand dollars. Until next time.